Okay, everybody's in.
All right. Hello, all. I want to start out by thanking the association for allowing me to speak at this year's virtual meeting. Hopefully next year we're all going to be in live meetings. I have adapted to the virtual concept, but I really appreciate seeing you and interacting with everybody. But thanks for being here, and thanks for supporting this presentation. I know some of the people that are on the list, I think I know, but I'll introduce myself briefly. Dennis Janisse. I am assistant professor of physical medicine rehab at the Medical College of Wisconsin. I'm a consultant for Dr. Comfort, a subsidiary of DGL Global. And I own National Pedorthic Services. National Pedorthic Services has been around for a little over 50 years at this stage of the game. I have scaled way back from where I used to be. Obviously, it's not a national company anymore, but I have actually closed both of the last two existing offices that I had, and I've got a small office in my hometown, about 35 miles north of Milwaukee, and actually doing quite well. I'm enjoying what I'm doing now. I'm by appointment only. I don't accept any insurance. I said that to an ONP, an orthotist in Iowa. I did the Iowa meeting, and he says, "Oh my gosh, that's like a dream." But with the referral source that I have, it's actually working pretty well. So that's sort of where I'm at this stage of the game. Still going to be out there as often as I can be working with all of you folks. And so this presentation, we're going to talk about the Charcot foot, Charcot arthropathy. And this presentation came about years ago. At one time, myself, National Pedorthic Services, both of my sons, Eric and Jeremy, we were responsible for a lot of the incoming pedorthic education. And some great schools came about. Really wasn't a need for us to be doing it. At that time, I was actually doing it as extra deputy university with P.W. Meyer. And I would go to meetings and hear people talk about, even in presentations, about peripheral neuropathy, and peripheral neuropathy seemed to be just, when they talked about it, it was just the sensory part of that. And that isn't what peripheral neuropathy is all about. There's so much more to it. And I'm not a physician. I'm not trying to be real technical. I can't, but I'm going to give you the sort of the short version of where I want to go with describing peripheral neuropathy. But peripheral neuropathy, just as a topic, is actually sort of boring. It's hard to relate to for us, or it was for me anyway. So I thought about the Charcot arthropathy, and we see, depending on what kind of a practice you see, we can see a lot of our Charcot in our practices. And that really involves three important concepts or parts of that peripheral neuropathy. So that was sort of, I decided I would do it with the Charcot, and that would be my way of bringing it all together. Well, as I've been doing this kind of thing, and I did that talk a couple times, I had a nurse, an anesthesiological nurse, wound care nurse, call me, and she said, "Could you do that presentation?" She was having a regional, which was quite a few states, a regional wound care meeting, and I'd like you to do that wound care talk, because she said, "I think a lot of our folks could use that." And I thought, you know, these are our wound care nurses. They certainly, if they're treating ulcerations on the foot involved with Charcot, they should certainly understand that. But I said, "How do you want me to change it?" And she said, "Don't change it at all. Just do it the way you did it at whatever meeting." I don't know how she ended up at a pedorthic or arthritic meeting, but she said, "Just do it that way." So I did it. And after I did that presentation, I had so many of these practitioners, nurses coming up to me saying, "That was great," because I had no idea why I was working with these terrible, ugly looking feet and the ulcers that they had. So I think it was a good plan to go there. And the reason I bring this up is a lot of the practitioners, a lot of the physicians that we're dealing with don't really understand it. Okay. So the reason I say that, 2 years ago, I think, yeah, it's 2 years because of COVID. I was at a meeting in The Hague, in Netherlands, and this is a great meeting. If you're interested in the diabetic foot, this particular meeting it only takes place every 4 years. Every 4 years, at the end of the meeting, they actually give an updated protocol for managing the diabetic foot. But at this meeting, because it's every 4 years, all the latest evidence, all the latest results of studies and everything else is management techniques are presented. So it's all updated every 4 years. So it's a fantastic meeting if you ever have the opportunity to go there. And Holland is a great city, a great country to go to. So you can have a lot of fun when you're there as well. But one of the presentations there really hit home with me because it was something that I felt that this wasn't real well understood, but I didn't have any evidence to show that except just personal experience. And this study was done, and it showed that up to 95% of cases of Charcot arthropathy are misdiagnosed. The average daily diagnosis was 29 weeks, and of the physicians surveyed, only 6.9% had excellent knowledge. 5% were good, 20.5% had a fair knowledge, but 67.6% of the physicians that were surveyed basically knew nothing about it. So it's really, really important. And I think it's so important that we understand what we're looking at. We're not diagnosticians, I'm not saying that, but we, by the same token, are working with those diabetes patients sometimes more than the physicians are. Depending on who it is, they may see them once a year or every couple of months. And if they're not recognized, they don't understand foot and ankle and understand the Charcot arthropathy, a lot of these people are mistreated. I've seen people that have had a Charcot ankle, went to an emergency room, and I'm not being critical of the emergency room docs, but they're supposed to know everything about any problem. And they look at it and think it's a sprained ankle, and they put an air splint on it, which is so totally inappropriate, because they should be totally immobilized because of what's going on with that foot. So I just liked, I really was impressed with that presentation, because it did reinforce what I said. And you use that if you have somebody that you suspect has Charcot, you may not be the best to just refer that person back to their general practitioner, because that person probably knows nothing about Charcot. And so it's got to be, when we're referring those people to somebody, it's got to be somebody that understands the process and understands the risks that are involved. So factors involved in the development of Charcot foot deformity, and these are just we're going to go through a lot of different things, but one of the things that I want to talk about is the fact that, depending on what author you look at, 0.08% to 7.5% of the diabetes population may have Charcot arthropathy or Charcot foot deformity. It's really a small percentage. In my particular practice, because especially now, I'm ending up with just the more serious stuff, because I don't accept insurance, and I'm getting a lot of people that have tried a lot of other things and it just doesn't work. So I'm seeing those kind of people. For me, there could be a day that it's 35–40% of the people that I see have a Charcot foot deformity. So depending on your setting, it can vary greatly. Now, I'm talking, I just put that up, it's that part of the diabetes population. I'll probably talk a little bit about it more later, but I don't want to forget it right now. We have to remember that Charcot is not unique to diabetes. It's not really a Charcot arthropathy is not the result of diabetes. The Charcot arthropathy is because of the peripheral neuropathy, and obviously in our diabetes population, probably the biggest patient population that has peripheral neuropathy. But this isn't necessarily a diabetes thing. You can see Charcot arthropathy in many different types of diseases. I've got one right now that was spina bifida. Could be arthritis. And there's just a lot of idiopathic peripheral neuropathy right now. I don't know about you, but I'm seeing more and more people coming in that have a total loss of sensation and a lot of the other things that goes along with peripheral neuropathy. And they've been tested, and the doctors do not know why they have peripheral neuropathy. A couple of years ago, I had a fellow that had a midfoot Charcot, just his whole midfoot was destroyed with the Charcot. And a doctor did a midfoot fusion on him. I was managing him, and he ended up with a dorsal ulcer and was supposed to be blamed on the shoe. Well, theoretically, I mean, it wasn't a shoe. Well, it was a shoe because there was a bone from that fusion that was protruding out of the top of his foot. So, and that's another situation. They did not know why he had the peripheral neuropathy. So it's a big part of our, I mean, it's a very, very small part of our diabetes population, but you're going to see a lot of people with Charcot arthropathy that don't have diabetes. And we have a tendency to just say, when you know it's Charcot and you say something about diabetes, and I've done that a couple of times, and it's like, no, I don't have diabetes. No, you're right, you don't. Okay, so average age of 57 years, that's immaterial really, and duration of diabetes, 15 years. That Charcot can be there. It can take a long time. I've got a gentleman right now, type 1 diabetes, and he's 66. Was diagnosed with diabetes as a child, and he's lost a couple toes, but he's got no Charcot. So it doesn't mean after having diabetes for a long time you're going to have it, but obviously if you have diabetes for a longer period of time, or you're managing your diabetes properly, then the risk of having the peripheral neuropathy is greater. And then, of course, there's a bigger risk of the Charcot. So just want to go through a little bit of where this is coming from. So factors involved in developing that Charcot foot deformity. So first, like I said, we know there's a sensory component to the Charcot foot, but it also, that peripheral neuropathy also affects the motor function, as well as the autonomic system. And there's really a combination of those three things that contribute to that deformity. Now, the theory that I'm going to give you today, and I say theory because there isn't really a good understanding of how this thing works. It's one of those things in medicine that happens. We certainly have found ways to treat it, how to manage it if possible, but it's not a real well understood. And there are different theories on how this whole thing takes place. What I'm going to tell you and what I want to share with you today is what I hear the most when I'm going to meetings, and I attend a lot of foot and ankle meetings, ADA, AADE. So I listen to a lot of lectures regarding this problem, this issue, and this one seems to make the most sense of some of them, of the theories. And there's just variations, obviously, of all of them. So we're going to start by talking about sensory and motor neuropathy. Now here we've got the loss of protective sensation. The monofilaments are great for that, and I'm sure we're all using those as we need to. I think in this day and age, there are so many patients that come in, and they're coming in from physicians that do understand the foot and ankle and diabetes. They've already been diagnosed with sensory loss or impaired sensation. So the 10-gram monofilament is a great tool. I remember when I started in Pedorthics, we used to all have a tuning fork, and that was also something that we used. And at that time, they hadn't really established that the 5.07 or 10-gram monofilament was the threshold of loss of protective sensation. That happened, and there was a lot of research done on that, and that was a great a great time when we realized that monofilament was the one. In clinic, I can remember in the foot and ankle clinic at the medical college, the physical therapist would have to go through all different types of monofilaments. It was a Sims-Weinstein set, and with all these different monofilaments to find out what they could feel in certain areas. Well, when they found out that 10-gram was the threshold for loss of protective sensation, it helped us so much. the tuning fork went away. Although I've been to some presentations at some of the big meetings, and as you know, it's drug companies and talking about studies on different medications now that theoretically are slowing down, stopping. I don't know about reversing the sensory loss or the peripheral neuropathy. So they find that that tuning fork on the base of the great toe nail defines and recognizes that loss of sensation much more accurately than the monofilament. So I think we may see that back, and I think in a fair amount of physicians' offices, wound care facilities, they're using vibratory sensory as a tool now. So that's part of the neuropathy. Then the other thing is altered muscle function, and we're going to see that because the commands for the muscle function aren't correct, are altered like the sensory feedback is. So the foot doesn't start to function well. And it can go either way. It can be a contraction type thing. And in our diabetes population, we can see a lot of cavus feet. That's because of that peripheral neuropathy. And you can see just flaccid and muscle weakness. You see equinus deformities, and a lot of the equinus deformity can be responsible for a lot of forefoot ulcerations. So we're sort of setting the stage for the next process that I'm going to talk about. We've got loss of protective sensation, and we've got altered muscle function. So we're sort of setting the stage for some sort of minor trauma. All right. So the minor trauma can be repetitive moderate stress, repetitive impulse loading, dropping something on someone's foot, and the trauma that I'm talking about would be, I usually, compare it to hanging a picture. You've got to hang a picture on the wall, and you're trying to hold this little nail, and you hit your thumb with the hammer. Well, that hurts like the bejeebers, and it may swell up a little bit. It will get red, probably warm. Why is it doing that? Because the brain said, your system said, oh, there's an injury on the thumb, and extra blood is sent there to repair it, to protect it, whatever it's doing. So you on that thumb, it gets red and swollen, and it's obviously painful and probably warm. That's because of that trauma. Well, here in the foot, it could be minor trauma, like I said, from walking or stumbling, hitting your foot with something. And the same thing happens. Your system is going to send extra blood to that part of the foot because there was an injury or some sort of a trauma. Could even be inadequately protected fractures and sprains, and then sometimes surgery. Surgery is a lot of trauma to the foot, and theoretically that could be the stimulus for the next step that we're going to talk about. And that next step is involves the autonomic neuropathy. So as I said before, we get that little bit of trauma, your system sends extra blood there. But when I hit my thumb, how long was that extra blood there? I don't know, 10 minutes, 15 minutes, a half an hour. I don't know how long it was really going there, but it wasn't for a long period of time. Because of the autonomic system being affected by the peripheral neuropathy, the system doesn't shut down that blood flow in a very short period of time. Okay, so you get increased peripheral blood flow and increased blood flow. In other words, wherever that trauma was, not the whole foot, wherever that trauma was, there's going to be increased blood flow to that particular area. Now, not for 2 hours, not for a day, sometimes for weeks or even months. Okay, unlike the thumb, a short period of time, here you get that increased blood flow to the bone and all the surrounding tissue structures. You get increased blood flow, and in a very short period of time, the bones become overloaded with all this blood flow, and they literally disintegrate and fall apart. So you can see this is a Charcot ankle. You can't see any joint spaces whatsoever. It's like a cloud. And that's actually what happens. You get this terrible destruction of all of that bone. It basically just falls apart. And if it's unprotected, obviously you can imagine that's where so much of the deformity comes from. So the stages of the development here, in the acute stage, you get swelling and joint effusion. Just talked some about that. Local elevation in skin temperature and bone resorption and softening from that hyperemia. But the key, I mean, an important thing to think about, the ligaments are weakened through the same process. Okay, so here you can see now this one foot, the left foot is certainly farther forward than the right is, but look at the size of this foot compared to this one. You can see this whole area is just so swollen, and it's hard to see on the slide, but there is redness here. There's swelling, and probably it's, well, not probably, it's going to be warm as well. Okay, that means that that Charcot process is acute. It's taking its place, and that bone is just disintegrating. And that person should be immobilized as soon as possible. Okay, and of course, these people are going to be insensate. For the most part, I would almost have to say they're all going to be insensate, because the Charcot is sort of the end stage of that whole peripheral neuropathy. The longer they've had it, the more prone they are to this possibly happening, and the longer they've had peripheral neuropathy, the chances of them being insensate is going to be greater. So they aren't going to really be too concerned about this. And I won't say I've diagnosed, but I've sent a lot of these patients back to the doctor when they've come in to see me and they've got this red hot swollen foot or part of their foot for no reason. I mean, you look at it, one of the first things you'd think about obviously would be infection. And that's obviously a possibility. But if there's not a portal for entry, if there's not, I don't mean to be gross, but there's not an area that there's some pus or some blood or something coming out of their foot, then there may be you wouldn't think there's a way that the infection got in there. And there's a fair possibility, if they have diabetes and all the other things that I've talked about, that they have Charcot. I have sent people back to their doctors, and that isn't something I can remember. One lady that I had taken care of her for years, and she made an appointment for an adjustment because her shoe was too tight. And so that was sort of strange, because she'd had the shoes for like 6 months. It was a regular patient, renewing her footwear all the time. So she came in and she said, something's wrong with this shoe. You've got to stretch it because it's way too tight on my foot. And this isn't her, but I mean, I took her shoe off. There was no comparison in size of the two shoes. It was red and hot. And I said, I think you've got more. I can stretch the shoe, but that's not the issue. You've got to get back to see. And I knew the doctor, a podiatrist, that I did a lot. He did a lot of work with diabetes patients. I said, you've got to get back to see the doctor. Well, she said, it's 2 weeks before Christmas. And she said, I've been working overtime at the deli, at the grocery store, and I've got presents to wrap and more shopping. And she said, I don't have time right now. She said, I'll go after Christmas. And I tried to convince her, but there was no talking to her. So I called her doctor and talked to her doctor, told him what I saw. She listened to him. She came in to see him. And then she was not happy with me for a while because she spent Christmas in a total contact cast. But, if she would have continued to walk on that foot, she didn't have a lot of deformity when I saw her, because it must have been fairly recent that the process started. And you can appreciate, if they're walking on that ankle that I showed you, there's just going to be so much deformity, and we want to limit that deformity. And the only way we can do that is by casting them, putting them into a removable walker, something. We've got to immobilize that foot and hold it in an appropriate position. Now, I bring that up because the reason I say that is eventually, and it can eventually, but I say eventually, it can take months for that blood flow to slow down and ultimately stop. And theoretically, those people have to be immobilized for that entire time. And I know that seems like a major time to be in a cast or a boot, but it has to be. I remember one patient I was working with, a doctor, and the guy had been to this gentleman had been to 2 or 3 uh, other physicians, and supposedly they didn't even know what they were dealing with. They had no idea what was going on. They couldn't do anything about the swelling, and he came in a pair of really fancy pointed-toed dress shoes, and his foot was just bulging out over the top. And it's a physician. He's actually a good friend of mine. He took one look, and he read the notes, looked at the X-rays. Not that they mean a whole lot, but he looked at the man. And he says, "Well, I know what you've got." And he says, "Well, thank goodness." He says, "Nobody else even knows what's going on. I'm so glad." He says, "Can you operate on me, or what can you do?" And he said, "We're going to put you in a cast." And he said, "Well, for how long?" And the doctor said, "Well," and he's very conservative. He said, "It could be 3 or 4 months." And the guy just looked at him. He says, "Well, I can't do that." He said, "I can't be in a cast." And he says, "You've got to do something else." And there isn't anything else. So the man walked out of there in his fancy shoes, and he may have ended up with an amputation somewhere along the line, because he totally refused to accept that care. And it sounds crazy, but the casting is the only thing, or the immobilization is the only thing you can do. That you compression hose, medications. There are studies now done, and I think that there's some promising things coming out of some of the studies that are done of medications that might be able to slow this process down and decrease the deformity and that we see. But there's nothing out there just yet. And so really what you have to do, you have to mobilize it while it's going through the process. You mobilize it long enough until that blood flow finally slows down, till the system says, as far as I know, there's no way to get it to slow down. It's going to slow down. It's going to stop on its own. So you want to mobilize it, keep it in the most workable position as possible, so that when it starts to coalesce, what happens, literally, there's new bone formation. The bones that are there start to fuse, and you end up with a very, very rigid structure. But by having it immobilized, you've got a structure that hopefully will be able to put a shoe around, if need be, a brace, whatever it is, that we can maintain that foot after the whole process stops. So it's got to be immobilized, held in as decent a position as possible until the whole process turns around and we've got new, a good solid fusion. Now that's an easy thing to say. We get some fusion, but you're going to have a lot of deformity. On this picture here, you can see some bony prominences sticking out. Now, is that a piece of bone from the destruction that the Charcot did, or is it some bone that just is growing out of the bottom of the foot? So you can get it still can be a big challenge. It's not an easy foot to manage, but then we have something, and we can probably build something around that foot to protect it and maintain it. Obviously, there's going to be joint mobility. As I said before, the immobilization of it doesn't necessarily stop that blood flow. It just maintains positioning. I had one gentleman that came to me for an ulcer, and we got it. The doctor got it closed pretty quickly, as I was able to maintain his foot. But he had Charcot on both of his feet. He didn't even know what that word was. He obviously had Charcot bilaterally and walked his way through it. So it was the typical, sort of rocker bottom foot type of foot. But he had walked through it and didn't even recognize and didn't know it. Well, the problem was it was never immobilized. So his foot was like a skeleton with the elastic in it. It was so unbelievably mobile and flexible that I found that a lot harder to manage than that rigid foot. You see, with a foot that's hyper flexible and no sensation, prone to amputation, ulceration, that was a harder foot to manage than the rigid ones. So stages of development, you get the reconstruction. I just talked about that. So there'll be increased stabilization. increased bone density and sclerosis, and then a lot of deformity. I mean, this is a gentleman that you can see here, terrible, terrible medial collapse. This is a rigid hallux, hallux varus. And we built a custom shoe around that. And he actually kept that foot. I mean, he was able to walk on it. He never had an ulceration. He got to the doctor early enough that they casted it, immobilized it, and maintained that foot. I took care of a lot of custom shoes for him. When he passed away, his wife brought me all of these, his custom shoes. She said, "Here, I'm going to bring these to you. Maybe somebody else can use them." Well, I don't think I've ever seen a foot exactly like that again. So never got to reuse his shoes. It was a good example, though. So common areas of involvement, and we'll look at that, but obviously you've got the patterns of bone joint destruction. Deformity increases risk, and obviously that pressure results in ulceration. Here's a fella that had our typical rocker bottom foot. I'm sure most of you have seen this a foot similar to this. And the surgeon that he went to, put a skin graft on the most plantar aspect of his foot. That was fun. And the doctor wrote a prescription. He didn't really understand Pedorthics, but he knew the guy needed something. He wrote a prescription for a shoe with an insole 2 inches deep and a hole. Well, I'm not a big fan of holes in foot orthoses, but I called him and tried to discuss it with him, and his attitude was he was a doctor and I was supposed to do what he told me to do. So I did. He's so full because of that Charcot in the midfoot. You can see how thick that midfoot was, and then there's so much deformity on the bottom. So I made him a custom shoe with a real thick, and probably was 2 inches of insole, primarily a more accommodating type material, but it had a hole in it. And eventually, and I don't know if you can see it, his skin graft started to break down. Well, the reason that was breaking down is because every time he took a step, that prominence with the skin graft on the bottom of it was being stretched. That's why I'm not a big fan of holes. And sometimes I even see window edema when we see a situation like that they've got a hole in their foot orthotic. Well, eventually that started to let go. It was letting go on the peripheral edge of that skin graft. So they asked me, they said, "Do you think that's supposed to happen?" And I said, "No, I don't really think so." and they said, "Well, the doctor doesn't seem to be too concerned about it." And I said, "Well, you're always welcome to a second opinion. And you have to be very careful. You obviously don't want to refer any of your patients away from the referring physician, but this was a bad situation." And so I gave him a couple of names of people that I knew they'd understand what was going on. And they did seek out another physician. And all we did, we talked about it after they saw another physician, we filled that hole with a soft viscoelastic polymer. So we still had total contact. We always want total contact, but then we had total contact, but with a real soft material under that skin graft, and it healed right up, and we were successful. Okay, so here, just look at patterns of where that Charcot can be. Again, as I said before, that the Charcot arthropathy is going to be in the place where we had the trauma. Okay, so you can have Charcot up here in the tarsal phalangeal joints. I've had 2 or 3 guys that have had Charcot of the IP joint of the great toe. Now it seems a little bit crazy, but I could just imagine in the middle of the night he probably rammed it up against the wall or something going to the bathroom. I don't know, but I've seen Charcot just of toes, and so it can be up there. I would say the most popular area is right here in the tarsal metatarsal joints, in that midfoot area, and then we get as we all know and have worked with, that rocker bottom foot. And I think that's probably one of the very common ones that we see. And I have sort of a theory on that we talk about the trauma with a lot of our elderly population. Right now we're talking about the diabetes. Yeah, if I'm referring to the diabetes, a lot of those people are more sedentary, and their foot actually goes into some equinus. And with some of the terrible shoes that are on the market today, there's so many shoes out there that are advertising being lightweight and soft and squishy. Well, some of them they've got marshmallows for soles. There's no structure to them whatsoever. So if you've got somebody that's in equinus and they're wearing a shoe with no structure whatsoever, where's that foot going to break? Where's the trauma going to be? It's going to be right in this midfoot, right here. So I think that's contributing to some of that. You can go back further into the midfoot. Charcot ankles, we see a lot of those. And I personally, as a pedorthist, I know I've got orthotists and prosthetists probably on this call with me on this presentation. That Charcot ankle, most of the time, unless the physician does a fusion, I've got work with some physicians that will actually do ankle fusions on the diabetes patients. But if it's just trying to heal that, that's a pretty important big weight bearing structure, that ankle joint. To really maintain those well is, I find one of the best ways is a crow boot, and get it to our orthotist friends. And a crow boot is probably one of the best ways to manage a Charcot ankle. And then supposedly there are Charcot calcaneuses that I've never seen. That one I haven't run across yet. So obviously deformity increases the risk and the pressure. So here, I know hopefully you're not eating breakfast while you're listening to me here, but here you see a really severe Charcot. Now this was actually, John Gould was the chairman of the orthopedic department for a number of years. And this lady came into the medical college right after he came to town, and he introduced us all to total contact casting. I mean, this is many, many years ago. And this lady came into clinic with that foot. And I think in a lot of facilities, maybe even today, that might be an amputation, because it looks horrendous. It looks terrible. And Dr. Gould said we were going to heal it with total contact casting. So, and it's hard to imagine that somebody was walking around with a foot that looked like that. But remember, these people have no sensation whatsoever. If you or I had that foot right now, I don't think we'd be sitting looking at our computers. And it just you see all this callus. I mean, she probably had this for months. And you know what happens with these folks? They hear about friends of theirs that lost they had to have amputations. And I think what they do is they're afraid to go to the physician. They wait to go to the physician because they assume they know what's going to happen to them. And as a result, the situation gets worse and worse and worse. That's why we play a major role here if we can get them to the physicians earlier rather than later. Well, anyway, so I remember when they debride this, the blood would just be coming out of here, because you have to get rid of all that callus and get to real viable skin that's going to heal. And so it's got to be debrided, totally debrided. Then it was put into a total contact cast. And that cast would be changed every couple of weeks. And that callus, it takes a long time for that callus to stop, for the body to stop producing that callus. So you'd be surprised in the beginning, even though they've redistributed the weight with the total contact cast. After a couple of weeks, they're going to have to debride a lot of that callus again, and they have to do that because they have to get viable skin so that will really and truly close and be a strong closure with as little scar tissue as possible. So that's what happened with this lady, and she went through the process. It was I don't know how many months, but it obviously took a long time for that much of an area to heal up. But this is her foot. And you can see all of this skin is all new skin, plantar skin, a little bit of a scar tissue right there. And remember, whatever caused that is inside of her foot. They didn't do any surgery on that. So whatever caused this is still right under the scar tissue. But this is going to be a lot easier to maintain than that gentleman I showed you earlier with the skin graft on the bottom of it. Well, this was early on when Dr. Gould came to town, and so of course then she was turned over to me for maintenance. And I was scared to death something was going to happen to that. So I had her coming back every couple of weeks, just to be sure that everything was okay. And she came in one day and she was in the waiting area, said, "How are you doing?" And she said, "Oh, fine. You're going to be, you'll be real happy." So we got in there, and I took her shoes and her socks off. She actually she had a calf lacer for quite a while. Took her brace off, took her shoes and her socks off, and there was blood on her sock. And I said, "What's going on?" And she says, "Well, I don't know. My foot's fine." And I said, I looked down, and this is the picture that day. You can see there's no blood here whatsoever. I looked up at the end of her toe, and I said, "What happened to the end of your toe?" And she says, "Well, I wanted you to be happy with my feet." She said, "I trimmed my toenails this morning." So when she trimmed her toenails, she took the little tip of the skin off of the end of her toe and didn't even know it when she did it. So I like to tell this story because it just helps us understand how some of these people, not all diabetes patients, but so many of our patients have virtually no sensation whatsoever. We can't ask them how the shoe fits. We've got to see them often to be sure that what we're providing for them is functioning properly, or they could really get into trouble. All right, so let's talk some about pedorthic management of the Charcot foot. Start with some objectives. So accommodate fixed or flexible deformities. And here, very often, if they were managed properly and the management was effective, you'll have a fixed deformity, as I said before, maybe a fairly rigid structure. But we can build a custom shoe, a shoe with rocker soles, all different types of things around that foot to protect it. Or we can have a flexible deformity. And as a guy that I for an example that I said was never casted, so his foot was hyperflexible. Want a stricter control joint motion. If there are joints that are still there, they're going to be overused. Actually, if we have a midfoot fusion, the joints distally and proximally, if we don't do something to provide or replace that motion, they're going to be either destroyed or overused, or potentially could be another Charcot episode. Relieve or transfer pressure. Obviously, with the Charcot feet, you're probably going to have bony prominences. You're going to have an abnormal structure or shape. So there are going to be pressure points. Improve gait patterns and decrease weight bearing on the foot if we have to. So those are pretty much the objectives we're going to look at with Pedorthic. We start with shoes. It would be nice to have a shoe that's wider in the midfoot, because very often the Charcot involvement is in that midfoot area. So we want to have a shoe that's going to try and accommodate it. A blucher opening or a modified ball, but a blucher is such a good opening because the foot is no longer flexible. So if we've got that rigid foot, it's hard to put it into the shoe and get it down there. So we need a shoe that's going to open up fairly wide, and the bluchers are the best. Obviously, we wouldn't even consider something like this, but I put things up just to show people will want something like that. And in this case, something like that isn't even appropriate. I'd like to say long counters. We don't have many shoes with long counters anymore, but a shoe with a strong counter. We want to try and control this foot because we've got to keep it in place so that we can provide the appropriate reliefs and motion replacements, all the different things we're going to do. And shock absorbing soles. Now I say shock absorbing soles, again, I go back to being critical of some of the shoes that are out there. We want shock absorption, but we don't want something soft and squishy that's going to be bottomed out in no time whatsoever. Custom shoes. Here's that fellow that we had looked at earlier, seeing the plantar aspect. Like I said, this guy never had any kind of an ulceration. He's got this big prominence on the medial aspect, and you can see there's no callus there whatsoever. So we with our custom shoes, we do everything that we do with our regular objectives. Transfer forces, support, accommodate, control, contain the foot. We have to contain that and keep it in the shoe, reduce shear shock, and improved gait. So when we built his shoe, I made it a high top because I need to protect this whole medial aspect of his foot. So I made it a high top with the insert or the insole. Make sure that that really accommodates the foot. When you're making a custom shoe, remember it's a custom shoe. Don't just pick a picture out of a catalog. Make sure that it's customized for that patient. Here I wanted that insole to come up all the way above this deformity right here. I made it a high top with a padded collar and put Velcro straps and built a rocker sole into it. He wanted to be able to be as independent as he could, so I didn't worry about laces. I used the Velcro so that he could put it on the floor. He was a big man. It was pretty hard for him to get down to his feet. So I made the counter strong so that he could slip his foot in and then use the Velcro to close it. So when it's custom shoes, make sure it's custom for that patient. Shoe modifications, medial and or lateral sole and heel flare. That's great for stabilization. Sometimes even though that foot is rigid, if it's hanging over the side of the shoe somewhat, people feel unstable. So a flare, and just even in a situation like that, the foot's not going anywhere anyway, but we want to give them stability, reduce the medial and lateral tilt of the foot, ligament strain, and basically just give us a broader base of support. Some of the shoes that are out there don't have a real broad base of support. So again, there's going to be a feeling of falling off of the side of the sole. The flares come in very, very handy and very helpful. The rocker bottom sole, we can design that for the shape of that foot as well. And we talked earlier about the fact that we've got that rocker bottom foot. Well, on that rocker bottom foot, there's so much pressure on that part of the rockers, the foot that's so far down. I mean, that's so posterior. So this is something that there's been some great research done on. It's called a double rocker sole. I mean, a typical rocker sole it's rocked on the toe and the heel. This one has a rock on the toe and the heel, but it also has a depression in the middle. So it's really like two rocker soles. That's why we call it a double rocker sole. And we make this part in the middle the thinnest right under that prominence that we're going to be trying to relieve the pressure, where we're trying to relieve the pressure. Now, in the study that I actually privileged to be a part of that study, comparing the double rocker sole to a traditional rocker sole, we had a sensor in that midfoot, and we were using normal subjects. So our sensor on a normal subject was the base of the fifth metatarsal. The double rocker sole didn't decrease pressure real significantly. It only decreased pressure by 4%. So bear with me. This double rocker sole only decreased pressure on the midfoot by 4%. But the traditional rocker sole increased pressure by 48%. Okay, so if you've got that rocker bottom foot, you'd actually be better leaving them in a plain shoe than in a traditional rocker sole, because you're dramatically increasing pressure on that midfoot deformity. So if you use the study and the numbers that we had, if you use the double rocker sole compared to the other two types of rocker soles that were more traditional, you're increasing pressure by 55%. Now you say, why don't we just not modify the shoe then? Well, because of the Charcot arthropathy and what happened as a result of that, you've got a rigid foot. So it would be, you need to replace some of that motion with the rock that you're going to get out of the shoe. But if it has that rocker bottom foot, then I would advise, and I always use, a double rocker sole. They all had shanks. I still put a shank into it because you don't want it to be soft and squishy. If it was bouncing around all the time, that may even start the Charcot arthropathy again and be some minor trauma. So do the shank and do that double rocker sole for those rocker bottom feet. And if it's a 4-foot type deformity, then you probably would want to use a 4-foot type rock. Use that rocker sole specifically for what you're trying to accomplish. A rocker sole is not a rocker sole. You need to look at what you want to accomplish with it and build a rocker sole that way. Okay, and then this is sort of like a flare, but just coming up the side of the shoe. I mean, you can get so much more control with something like that coming up the side of the shoe, but always remember that if you're working with the Charcot patients, they probably have little to no sensation whatsoever. So you really do run a risk of causing pressure here. You need a patient that's really going to take responsibility for themselves, so that you don't get yourself in trouble here. And then the relasting, and I think a lot of you that you've listened to me talk before, the relasting is such a valuable tool here, and it actually saves me from having to do custom shoes sometimes. Not that I'm against custom shoes, but if you can relast a shoe, reshape the shoe to the shape of the person's foot, acceptance sometimes is better than the custom shoes. I mean, people like they in their minds, they like the fact that they took a shoe off the shelf, and it's a shoe that anybody else could wear. Of course, they can't wear it after we've done the modifications to it, but compliance is better. And in many cases, being able to modify the shoe, you can provide footwear a little quicker to the patient as well. So basically what we do here is we take the sole off and cut through the midsole and the insole. And it's nice today that so many of the shoes have EVA midsoles. They're a lot easier to work with. And then you expand this and fill this in with something. I use a firm mixture of viscoelastic polymer to fill in that area. And I put a piece of like a file folder inside, so that when you pour this from the street side of the shoe, then the insole of the shoe is totally flat and smooth. And then you can build your rocker sole onto it, and you can really accommodate a lot of deformities with the relasting. Obviously, some of the feet that I've already shown you, it would be impossible to relast the shoe. You need an actual custom shoe made around a cast of that person's foot. The total contact orthoses, again, a variety of different types of materials. Very, very important when we're building that foot orthosis to be able to offload different types of prominences on the plantar aspect of the foot. Can be a variety of different materials, as I said before. I'm always an advocate of plastizote, an eighth of an inch of plastizote on top of my orthosis. I know there's, obviously low density EVAs as well, and a lot of people are using that. Primarily, I think because of cost, but I personally don't think that they accommodate little minor deformities as good as plastizote does. But always understand it's going to be gone in a very short period of time under the pressure areas. But you can use that as a guide when you look at the foot orthosis to see if you're adequately unloading in a particular area. If the area around the prominence is all an eighth of an inch thick yet, and where the prominence is, it's totally bottomed out, then you haven't done everything you can to offload that particular area. So I'm a big fan of the plastizote. So stabilize and restrict joint motion, reduce impact shock, accommodate decrease shear, and equalize weight bearing. So ankle foot orthoses, real quick. Obviously, I am not an orthotist, so I'm not going to be the expert here, but I'm going to just go through it sort of quickly. The types of AFOs, and again, double upright calf lacer. Now, I don't see a lot of these anymore, although when I go, as I think some of you know, I do a lot of lecturing around the country. I've had pockets where orthotists say they still do a lot of these. I've got one physician in particular that still likes this. Maybe not. Yeah, it depends on the patient, because the patient's only going to be able to wear one shoe or multiple shoes with braces on. But it can be a substitute for the crow walker. And with the crow walker, that's all they're able to wear. And this can work. And it does help off weight the foot some. What I like about this compared to the crow walker is I can still work with the shoe, and if there's an issue on the plantar aspect of the foot, I have a lot of control because I can modify that foot orthotic. Inside the crow walker, we're limited to how much we can add or subtract, because if we do too much, then the rest of the brace doesn't match accommodate the foot appropriately, and you can get some breakdown because of that. So I know that they're using leather and things today isn't as popular, and I think there's a lot of in the orthotic industry as well as physicians lean toward the crow walker, and I'm not negative to that, but I want to say that the double upright calf lacer still has a place, and it does work. You can have patella tendon bearing AFOs that may help offload. The crow, I mean the crow walker, I'm a big advocate of it. I don't know if I'm really an advocate of it for healing the ulcers. And I know sometimes it's used for healing ulcers, but some of the feet that I've seen, some of the Charcot deformities with the swelling are so big, you don't even see any definition of the foot. And if you invest the money in a crow to go over that, and you'd be surprised how much bulk goes away as that blood flow stops. It's hard to make that crow adequately fit the foot anymore. So I think the crow is good for immobilization after, but I'm not a big fan of it for the total contact casting, because you sort of burn up the allowance for that crow if you're using it for in place of the total contact casting. It makes more sense to me and the physicians I work with to use it after the foot is stabilized. Okay, ankle gauntlet, unweighing AFO. You know, I had questions about this, whether this really and truly can offload the foot or off-weight the foot. But I've had some orthotists that tell me they've used it in very, very effectively. So that's obviously something that's a little less bulky, and we can use in other shoes. So that's definitely an option. So keys to success: importance of proper fit, 2 to 3 pair of shoes, which of course today we've got an issue with if people are on Medicare. Unfortunately, so many people don't want to have to pay for anything if there's an allowance, but people would benefit from a couple of pair of shoes because they have to wear these shoes. Our Charcot patients should be putting their shoes on when they get out of bed in the morning and not taking them off till they go to bed. So the shoes need a little time. They would last longer. 2 pair of foot orthoses would be so advantageous to have, because those materials do bottom out and they'll rebound after if they've got some rest. And of course, with these patients, we need a lot of follow-up visits. It's very, very important to have our follow-up visits, because the foot can change, the materials that we're using for orthoses and the shoe modifications, all those things can change. So I really encourage these people to follow up with me. I'd like it every 3 to 6 months. And we actually send reminder cards out every 6 months for them to get back and at least to see us for follow-up. So in conclusion, we really can help these folks a lot. You know, they can be very challenging, but they can be very rewarding at the same time. And I hope you enjoyed what I had to give you today, and enjoy the rest of the program. Take care.
Thanks, Dennis. Okay, everybody, I'm going to send the survey over and you can fill that out. And then Dennis's next presentation will start shortly. So fill out the survey. Kara is still answering questions in the prosthetic session. The orthotic session will start as soon as she's finished answering all of the questions. So don't worry. You can switch rooms if you want. You can go ahead and do that, and I will let you into that in just a minute. So
I'll be right back.
Yeah, you want to turn your camera off?
Well, they can just look at my room here.
Okay, well,
I don't. How do
wash
I
your hands before you come back?
Up your nose. Do I just say stop share?
No, you're fine. You can leave it.
All right.
Okay.
Everybody can look at my all on my.
Yep. Everybody can spy into your office.